Welcome to our webinar series for professionals.
Hi everyone, and it's good that you have your videos on so we can see each other at least. Anyway, I'm in Seattle now. It's early morning and it's dark outside. So, but I'm still on European time. But the topic of today with stress is matching with jet lag quite well. So anyway, I'm Anne-Catherine, co-founder of Nordic Laboratories and DNA Life, a group of companies that is dedicated to change healthcare through functional medicine, personalized lifestyle, using functional tests, genetic tests, good quality supplements, etc. So before we dive further in, I just want to announce that we have the next webinar on the 27th of October, which is on prevention and treatment of dementia with two of our practitioners from South Africa who wanted to extend their knowledge to all of you practitioners out there around the globe. And then for those who's able to travel to Stockholm, then we have the Nordic conference on the 11th and to the 13th of November. It's on mold, toxic exposure, organic acid, and much more, cancer prevention, etc. So I hope to see you there for sure, in person, and give hugs. So that would be very, very nice. So today we have Ben Brown in the studio, if we can call it that, or on the stage, as I say sometimes. He's a naturopathic doctor, and he has a long list of things that he does. And he's very busy this weekend because he has a conference in London with the Nutritional Medicine Institute. So I'm very honored that he has the time now to present to us. He's also on advisory board of BCNH College of Nutrition and Health, and an advisor for Health Food Manufacturer Association. And then he writes articles for different magazines and edits journals and educates. And his role today is as a consultant for Pure Encapsulation, so a supplement company. And then, just to round it off, he also has a podcast. So there's a man on a mission here who's dedicated again to spread knowledge and information to as many people as possible. So the title of today is Stress and the HPA Axis, Dysfunction and Opportunity for Personalized Nutrition. And that fits quite well for me, with me sitting here in Seattle being jet lagged. I was in the US last week as well, so I'm double jet lagged. But and then again, just all the things that goes on around the world with all the financial strains and wars, etc. I mean, there's many things going on, and it impacts us, of course, our stress levels, what's the future going to be like, etc. So I very much welcome this presentation from you, Ben. So you can share your screen now and show your face. There he is. And remember, you can write questions or comments in the note box, and I will take them down, and we do the Q&A at the end of the presentation. And we do a recording, so we will share the recording as well after, probably next week. And the slides have been shared with us already, so we will forward that together with the presentation to those of you who have signed up. So there you go, Ben. The stage is yours.
Terrific. Thank you. Lost a little bit of images there. Let me see if I can just correct that. 1 second.
No problem. I'm just letting a handful more people in.
Terrific. Yeah, that's really weird. Just wondering how I can fix that. Give me 1 second. Okay, I think I found a solution. That's cool. Okay, sorry, a little bit of technical difficulty, but we're on. So thank you for the kind introduction, and also thank you for the invitation to be here. It's a privilege to be speaking to the group. A lot of respect for Nordic Labs and all the good work that you're doing globally. So it's nice to connect in with everyone who's part of this tribe and movement. And this topic really speaks to the movement of integrative and personalized medicine. And it really is one of those foundational topics that really form a core element of good patient care. And for some of you are really advanced at this, art of integrative medicine, it'll be a bit of a refresher. And for some others of you, I hope that this really helps uncover a very important avenue for improving patient care. As was really rightly pointed out, is that this is fundamental, and it's intimately intertwined with everything that's going on in the world. But more, we can't really control a lot of that, but what we can do is improve our resilience to a lot of the things that are going on around us through modifiable, elements of a patient's lifestyle, behavior, and nutrition, which is what our focus is going to be on. There are obviously elements of this that dovetail beautifully into sort of lifestyle medicine and more integrative mind-body type approaches and things, but we're going to keep the scope on nutrition, partly because it's one of my favorite topics, but also because we've got limited time to go much deeper than that or into other areas. I'm not really going to point out disclosures and affiliations. The only obvious conflict of interest I have that I want to announce is that I'm a consultant for Pure Encapsulations, but apart from that, there's nothing really to disclose. So let's get into the topic, and the topic is stress. And one of the challenges that we face with discussing and talking about the concept of stress is that it's very poorly defined, and our patients often have a sort of strange working definition of it, and so do practitioners often as well. What is stress? What does it mean? And what it really means is it's difficult to explain in a sort of simple phrase, but what we're going to do is expand on its biological definition with a very up-to-date understanding of the biology of stress. Now, a lot of you, if you did medical school in the last 20 years or so, you would have gone through medical school and sort of had a cursory covering of the topic of stress, and you probably would have learnt about the general adaptation syndrome and Hans-Selye and stress hormones like cortisol and noradrenaline, and that's all great, but a lot of that sort of working understanding of things like the general adaptation syndrome are grossly outdated and very old hat, basically. And what I want to do is sort of take that cursory understanding that a lot of us have and bring us forward into the 21st century. And really, the biology of stress is fascinating in the way it's evolved throughout science over time, and that's really shaped our understanding. It really, we give a great deal of thanks to Hans-Selye and the general adaptation syndrome, but a lot of what he was talking about was wrong, and a lot of the experimental models he was using were inherently wrong. One of my favorite examples is that he mostly experimented in mice, and most of the mice were men, meaning they had male biology, which really speaks to the male bias in the history of science and medicine. And so it turns out that a lot of what we understood about the stress response biologically was biased towards male biology and behavior, and we totally missed how that females respond differently. So you've heard of the fight and flight syndrome. Well, that's a male response to stress. The female response has been coined the friend and befriend response, because women are much more likely to socialize as an adaptive response rather than punch someone. So I think these sorts of things are really interesting. And, you know, moving forward from Hans Selye and these old ideas around stress, for me, the person that really brought us into the 21st century, unfortunately, he passed away just a couple of years ago, but he was a neuroscientist at the Rockefeller University in New York called Professor Bruce McEwen. Now, Bruce McEwen is credited with coining the term allostasis and allostatic load. Now, these may be foreign terms to some of you, and some of you may be familiar with them, but they're beautiful concepts, and they really help us understand stress in a much more integrative fashion. So I highly recommend reading anything by Bruce McEwen. His work was absolutely prolific in this area. I'll highlight a lot of key research papers, and we'll touch on what allostasis is as we go a little bit deeper into the biology. So really, this idea of allostatic load or allostasis or allostatic load can be broken down into two really simple concepts that all of us will understand. So allostasis refers to being stressed. So it's a challenge under acute stress. And allostatic load is what happens when we're stressed out. Now, this is a physiological response that's chronic and widespread under constant chronic stress. So stressed allostasis, so this short-term adaptive response, which we might think of as being more this traditional fight-flight type response in a sense, and allostatic load being a more integrative response throughout our biology. So that's really the core difference if you want to grossly simplify it, just for, you know, memory's sake. But to build on this, basically allostasis more specifically means achieving stability through change, which is a beautiful idea in itself and something to meditate on. But this involves the release of chemical mediators of the stress response. Now, most of us think of cortisol, which is a primary mediator of the stress response, but also sympathetic and parasympathetic hormones. But there's more than that. There is a lot of neurotransmitters like GABA and glutamic acid and serotonin and dopamine that are noradrenaline that are all involved in the stress response. There are cytokines, which we traditionally think of as immune mediators, but they're part of the stress response too, and they help us adapt to stress. And metabolic hormones, so things like thyroid hormones and gonadotrophic hormones and so on, are all part of the stress response. So you can see where this is going. This is not a simple, you know, response confined to the central nervous system and a few key hormones. This is a body-wide response that involves the neuroendocrine and immune systems, and they're all part of the stress response. There's no difference. The immune system, as everyone on this call I'm sure knows, is not different from the nervous system. They're intertwined, intercommunicating, and interconnected. So, you know, stability through change using these mediators, but then we have allostatic load where we have a constant chronic release of these mediators. So this is what's happening under chronic stress. Now, this can occur due to a few sort of conceptual phenomena. The first being listed as A here, and I'll build on this, so you don't need to get it all now, B and C and D, but A is repeated hits from multiple stresses. B is a lack of adaptation or habituation to stress, so an inability to adapt. C is a prolonged response due to a delayed shutdown of our stress response, and D is inadequate response that leads to compensatory hyperactivity of other mediators. So if we look at this visually, you know, and if we think of the physiological response as a release of mediators throughout our systemic sort of circulation, we can visualize that in the top box there. It's the physiological response with stress and elevation of mediators. And we go through an acute stage and, you know, that helps us adapt to response. And then hopefully with a good, healthy stress response, we we have adaptive behaviors. We are able to contextualize things so we can, respond to them more effectively. We have a physiological response as well that helps downplay the stress response over time, and we recover. And that's what we're looking at here over time is recovery in the latter stage. Now, when we look at allostatic load, there are a few phenomena that can drive that. One of them is repeated hits, as you can see there, lack of adaptation, prolonged response, or even an inadequate response as well. Now, these things, people don't live in boxes, and as you know, it's very hard to categorize people as this or that, but it's likely a combination of all of these things for many people, but it's an interesting way to sort of think about how this may be playing out on the biology of an individual. So the reason all of this is important is because stress is a key driver or contributor to multiple diseases. And this is not to say that stress is the cause of everything, just the same as inflammation or oxidative stress is not the cause of everything, but they are important contributory pathophysiological processes that often play a role in disease development. Now, if we look at acute stress, there are a number of things that we know can be triggered by acute stress, such as an allergic type response, vasomotor type symptoms, as well as gastrointestinal and psychological type symptoms, which you can see listed here, ranging from things as diverse as asthma, eczema, urticaria, migraines, hypertensive attacks, different pain syndromes, as well as in the gastrointestinal tract, often a weak spot for people, pain, indigestion, diarrhea, constipation, and so on, with anxiety and psychotic episodes. And then where this really starts to get vague is when we start to look at the relationship between chronic stress and disease, because basically you can link pretty much any chronic, non-communicable, and probably the communicable diseases too, to stress. So things like depression, anxiety, cognitive dysfunction, sleep disorders, and so on. So there's a lot to unravel here and unpack. And one of the ways we do that clinically is by having a good working understanding of the stress response in our patients, because that can then help us measure the response, identify appropriate treatments for that person, and personalize interventions based on this simple understanding. So if we look at the hypothalamic-pituitary-adrenal axis, which is what HPA stands for here, we have an integrated network of key effectors of the stress response throughout our biology. And it's a beautiful little system. So we have in the brain the hypothalamus and the pituitary, which are enlarged in this box here. And then the third component here is the adrenal, specifically the adrenal cortex. Now, the way this works is just magical. So we have stressful stimuli, which I often say, unless it's biological, because, injury and inflammation, oxidative stress, etc., are all forms of stress. But if it's in the environment, like worries about, the economy or war, etc., or maybe something less big, like a bit of road rage or, bills or something like that, what we have is something that's really starting in the ether. It's almost intangible. But the way it manifests as stress is through our own interpretation in the brain. So upwards of the hypothalamus, we have our cognition and interpretation and the areas of the brain, like our prefrontal cortex, that are conceptualizing things and experiencing things, and then sort of turning that experience into biology, which then changes the way our nervous system functions, and neurotransmitters are released and start to communicate. And it's that flood of electrical impulses and chemical biology and neurotransmitters in the centers of the brain that then trigger the hypothalamus to instigate a stress response. And the hypothalamus then sets off this chain of events. We have CRF, or corticotrophin releasing factor, binding to the anterior lobes of the pituitary, which then releases adrenocorticotrophin releasing hormone, which then floods through our systemic circulation down to our adrenal cortex and triggers the release of of cortisol. The sympathetic nervous system is activated much more acutely than the HPA axis, but it's activated in tandem within a millisecond sometimes of a stressful stimuli. This occurs much more slowly, and it takes about 40 minutes or so to get this cortisol flooding through systemic circulation and back up into the brain, where it acts as a negative feedback mechanism. So it's a beautiful system, and stress is good. And the stress response is fantastic. It's a wonderful thing to have because it helps us adapt to things like speaking to a group of Nordic practitioners. It activates my cognition. It improves cognitive vigilance. I'm able to think a little bit quicker, which is handy because I'm quite tired today. And off you go. So it can be very good, but we're not here to talk about the good side of the stress response. We're here really to understand pathophysiology. And the pathophysiology is really interesting in that we can start to look at how individuals respond differently to stress. And what we're looking at here is a graph that I've lifted from a paper. It's quite an old one now, but I like it because it's an excellent example of what I'm speaking about. In this paper, what they did is they took a bunch of people and they exposed them to a, actually, I can't remember. It was either a mental arithmetic test, like a maths test, or a public speaking test. It's typically those two challenges that are used in stress research. For me, it would be the maths. I can't stand maths, but public speaking, I don't mind so much, probably through habituation. So anyway, what they did is they measured the stress response in these people. And what you're looking at in this graph is plasma cortisol release after exposure to a experimental stress ore. And the fascinating thing about this is they were able to differentiate people based on the level of cortisol that was secreted in response to stress into high and low secretors of cortisol, because the difference is that wide between the two. Now, this is important because we know through this research and many, many other papers like it over the last 30 years or so, well, at least since the 90s, a lot of this great work has been done. That we know that people basically do respond differently physiologically, and that also can influence their behavioral and physical manifestations of stress differently as well. If you're a hyper responder, you tend to have different clinical symptoms compared to a hypo responder to stress. Now, a good question to ask is, why do some people have a hyper responsive and why do some people have a hypo responsive HPA axis function to stress? The answer is we don't know, but it would be wonderful to understand that it's probably genetics, it's probably environment, it's probably behavior, and likely a combination of all of those things. But definitely it's a phenomena that we see. And one of the best reviews in this area was published by a pioneering stress researcher who, to my mind, along with Bruce McEwen, is really credited with putting more advanced stress research on the map, by the name of George Crusos. And although this paper was published in 2009, I still feel like it's one of the best papers out there on the stress response, full stop. But what I've done is I've summarized some of the elements of that paper in a very simple table, and I've used some of my own wording on the third point and probably the first point a little bit as well. But the symptoms I didn't change, and these are documented and referenced in the paper. And you can see what's going on here is that basically, and also he doesn't use the term strung out or burnt out. They're my colloquialisms or simplifications of strung out being hypothalamic-pituitary-adrenal overactivity or hyperactivity, and burnout being HPA axis underactivity is commonly what they're referred to. But I kind of like to think of them as strung out and burnt out because it just makes a lot of sense to me. But that's what they are. And basically when someone is in this HPA axis hyperactivity, the brain and nervous system hyperreactive in response to stressful stimuli, whereas in people who are more burnt out or have HPA Axis hypoactivity, we tend to see an underfunction of the stress system. And this can result in a few phenomena which we'll explore, but essentially their central nervous system isn't responding and adapting as well to stressful stimuli. And that, I don't like using the word adrenal burnout because it's come under a lot of criticism, but that's essentially what it kind of is another sort of generalized term for what we're seeing here. So the symptoms, if you glance through those, you can see clear pictures, right? These are the kind of people that you see in your practice. Sometimes it's a mixture of both, so it's not always this clear, but sometimes you get people that fall into these boxes pretty clearly. So you'll have people with, anxiety and comorbid insomnia, with melancholic depression and OCD type tendencies and addictive tendencies. That's a very clear clinical behavioral picture sometimes. And the useful thing is that we can now understand a bit of the biology of that through the lens of the hypothalamic-pituitary-adrenal axis. And the same is true for burnt out. Like these people, tend to have hypersomnia rather than insomnia. They tend to have atypical rather than melancholic depression. It's a classic feature of chronic fatigue syndrome, somewhat also for fibromyalgia, certainly for post-traumatic stress disorder. And we also see similar phenomena in hypothyroidism, amongst other conditions, but these are some of the main ones that you'll encounter. So the usefulness of all of this, I think, and these are my words, I've not, this is not in the paper, but I think it really helps us through understanding the biology, understand possible treatment strategies. So for me, logically, if someone's strung out, you really want to work on helping calm down the brain and central nervous system in particular. Whereas while someone who's burnt out, you want to think about improving adrenal adaptation to stress and long-term resilience. So useful food for thought for now, and we'll build on those concepts and ideas. Before we get into the news to use stuff, like what can we action, I want to talk a little bit more about the central nervous system, specifically the brain, because for me, this is why, just crazy interesting. And I think it really helps us understand not only the biology of the stress response, but really helps us understand the biology, adaptability and plasticity and potential of our patients as well. So I've oversimplified it here, and I've done that intentionally, but what we have here is a very simple image I've knocked up. And here we start with chronic stress coupled with low resilience, because, often people who are experiencing, a lot of symptoms of stress don't necessarily have more stress in their life. One of the determining factors is often their resilience, not the stress per se. So chronic stress coupled with low resilience leads to hypothalamic-pituitary-adrenal axis activation, which increases these stress mediators systemically. Now, this is where it gets really interesting, is that these stress mediators can change brain structure and function. So arguably, this includes most mediators of the stress response, including stress hormones, cortisol and adrenaline, noradrenaline, the neurotransmitters, the cytokines, the sex hormones, and so on. But really the main elements of the mediators that are changing brain structure and function are cortisol, as well as some of the neurotransmitters, which we'll touch on in a moment. So these change structure and function, and this then results in a downward spiral because we see loss of brain re-regulation of stress. Now, let me explain that in a little bit more detail, because it starts to get really interesting. Am I going to explain it in a bit more detail? No, not going really deep on this, but I want to just expand on this verbally then. And what I'd like to say to this is that under chronic stress, you see atrophy of a few key regions of the brain: the prefrontal cortex, the hippocampus, and the hypothalamus, and you see hypertrophy of the amygdala. Now, this is really well documented, and basically the reason for this is these neurotransmitters and stress mediators are toxic to the brain. Cortisol can result in the death of neurons, and that's why we see atrophy in the prefrontal cortex. And they can also result in hypertrophy of other regions, being the amygdala. Now, those of you who know brain biology will know that the hippocampus, hypothalamus, and the prefrontal cortex are all the higher centers of the brain. They're the areas of our brain that are involved in memory and learning and emotional regulation, and are the most important areas for conceptualizing stress and helping us navigate it from a brain resilience perspective. And you'll also know that contrary to this, the amygdala, or in contrast, the amygdala is the fear center of the brain, right? So it's involved in this startle response to stress. It's often called this primal fight-flight center of the brain, which is exactly what it is. And under chronic stress, that hypertrophies, and you see bigger size of the amygdala, but also bigger activity of the amygdala. Now, the reason I'm telling you this is not to freak you out and think that there's no hope. In fact, it's the opposite, because where this really the rubber meets the road on this idea is that actually you can reverse this. So although under chronic stress, you see these brain changes in structure and function, it's a fact, it's not science fiction, that you can alter that, and you can increase the size of the prefrontal cortex and the hippocampus and the hypothalamus, and you can decrease the activity and size of the amygdala. This has been documented in the scientific literature. I'll show you some examples with nutrition, but in mind-body medicine in particular, and behavioral medicine, this is really well studied. So exercise, for example, causes profound changes in the brain through altering brain structure and function. So does meditation, so does yoga, and so on. But we're going to talk about nutrition, and where I really want this to, or what I really want to emphasize this is that we're going to focus a lot on the brain, but this really falls into a bigger picture of the whole health of the whole body of the whole individual that's sitting in front of us in the office, because it really is, as Bruce McEwen put it, it really is healthy mind, healthy body, and the two are tightly interconnected, and the management of mental health should incorporate a focus on physical health and vice versa. The two go hand in hand. We can't just prescribe drugs or nutrients for mental health and hope people that will get better. We need to take into account physical health at the same time. So it really is a big picture, integrated view of healthcare that everyone here is aligned with anyway. So let's talk about nutrition and how it fits into this concept and paradigm. So what I've done for the rest of the presentation is summarized interventions. We're going to look at the research that have been shown to alter stress biology, specifically the function of the hypothalamic-pituitary-adrenal axis, with evidence to show that they do things like lower cortisol, dampen the HPA axis response, or improve it if people are burnt out, and improve patient outcomes in terms of physical and mental symptoms. So that's really the sort of scope of the way we're going to look at these nutrients. And this may look really simple, but it's good to understand the nuances of things like diet, caffeine, B vitamins, magnesium, vitamin C, and omega-3 fatty acids. And then we'll look at a few things that can be used more acutely for improving adaptation of the HPA axis as well. So very briefly going to touch on diet, but what I want to say to diet is that it's undergone a renaissance in the last 10 years as an intervention for mental health. Really, the origins of integrative nutrition date back arguably for mental health that date back to the 1940s, and the work of Dr. Abraham Hoffer and then Linus Pauling and colleagues, where they were prescribing nutrients based on biochemical individuality to improve mental health outcomes. But it's really, since the 40s, it's really gone under the radar in terms of the science, but that's changed dramatically in the last 5-10 years. And what we're looking at here is the SMILES trial. Now, the SMILES trial was the first randomized controlled trial of diet for the treatment of depression. And it was only 2017. Like, how tragic is that in a way, but how beautiful that it's now been done. And there are now at least 5 studies like this in which diet has been used as an intervention for the management of mental health disorders, including depression. Now, the first trial is epic. It was headed up by Professor Felice Jacker at, anyway, I've forgotten the university. It's Deakin University in South Australia. And basically, what they were able to demonstrate was remarkable. To give you the headline, within 12 weeks of the intervention, 32% of the patients with depression had gone into remission, compared to 8% in the control group. Now, the control group was, they controlled for the personal contact that the patients received with the dietitians. So that's what they were controlling for. But the intervention group, they got the food changes as well as the personal contact, which we know can be beneficial. Now, to send 1 in 3 people with major depression who were resistant to drug treatment, as well, I might add, into complete remission within 12 weeks, it's like, show me a medicine that can do that. Well, it turns out that diet can do that. So it has a profound effect on our biology and mental health. And it's powerful and well documented and deserves more attention. And it has, of course, been shown, food has been shown to modify stress biology as well. Unfortunately, there's a lack of research in this area, but we do know that food and dietary changes can influence things like circulating cortisol and adrenaline, and as, of course, as we can see here, mood. In fact, there are studies which are intriguing of individual foods that have been used as like food prescriptions that have been shown to improve the cortisol response and lower elevated cortisol and improve mood and reduce symptoms of things like anxiety. And basically, there's a long list here, and I'm not saying we should give everyone every single one of these, but if you look at these and generalize the kind of foods they are, I think it just paints a bit of a picture. Green leafy vegetables sit at the top of the list, which we know are one of the most nutrient-dense foods that we could prescribe or recommend to patients. And because they're rich in lutein and zeaxanthin, which have powerful effects on the brain, they're able to lower cortisol and improve mood in this particular study. In fact, they lowered anxiety and depression as well. And it's the equivalent of just a cup of greens. And then things that are very high in polyphenols, things like pomegranate and blueberries and cherries, for example, these brightly colored fruits, because of this nutrient density, are able to exert positive effects on mood. And in this case, they also reduced cortisol. And then things like seeds and nuts, which again are very rich in phytonutrients, walnuts and flax seeds, were able to do things like buffer cortisol, and they have been shown to improve mood also. So I think all of this is really painting a picture of food as being very important. So a frequent question we often get in clinical practice is like, is coffee bad? And the answer is, it depends. And it really depends on 3 key things: your genetics, your habituation to coffee, and the absolute amount that you're consuming. I think are probably the key things to think about. But there is this often overgeneralization of the idea, particularly in sort of nutrition circles, is that coffee is bad. It isn't necessarily, it depends. And coffee is a cause of stress, and it isn't necessarily, it depends. The reason we know this is because the research is a bit ambiguous, and generally most of the research that people have malaligned with coffee has been on purified caffeine. Coffee is not purified caffeine. It's a nutritionally complex extract from the beans of a plant that contains a lot more than caffeine, including nutrients that modify the effects of caffeine. So the two are not the same thing. And while someone might feel quite stressed by consuming white crystalline caffeine in a clinical study, it doesn't mean the same effect is true of a cup of coffee. So what we do know from studies of actual coffee is that it has, in some people, but not everyone, a mild stimulating effect on the sympathetic nervous system. It doesn't tend to have a robust effect on cortisol. In fact, most studies have found that it doesn't increase it at all. But what it does do is it stops them falling, which may actually be a positive thing for some people if they need a bit of improved adaptive response to stress. And then, should we blacklist tea as well because that's got caffeine in it? Well, no, tea has even less caffeine, and it has even more phytonutrients that modify the effects of caffeine. In fact, it lowers post-stress cortisol and improves feelings of relaxation. So, it depends on the patient, of course, but in general, we want to be cautious about indiscriminately, having people avoid coffee and tea and things. It really should be a personalized decision. And then we need to move into a discussion around nutrients that we can prescribe that would be beneficial for people with stress. And this sounds really simple for those of you who are really nutrition literate. It's like, why is he even talking about B vitamins? Well, I'm talking about them because although they're old and boring and been around for decades and cheap and not very exciting, they're foundational and they're incredibly important. And they're one of the things that we know reliably improves people's mood. And they are deficient in, it's one of, it's like, sure, prescribe probiotics for mood. That's very exciting, but not if you after you've tried the foundational stuff that are really essential, like B vitamins. In fact, to my mind, you'll get much more bang for your buck therapeutically from a simple B complex than you will most fancy formulas for mood and depression and things. But of course, there's, apart from clinical experience, there's a bit of evidence for that. You're looking at a meta-analysis here of 8 randomized controlled trials of B vitamins or B vitamin rich multivitamins for mood. And generally what we see is within weeks, people feel better. And that most studies are around 30 days, you see a really significant improvement in mood, vitality, energy, and other symptoms. But what's important to understand is that dose matters. And the pioneers of orthomolecular medicine like Hoffer and Pauling were right. You need more than the RDA. The RDA is not sufficient for most people. And as David Kennedy summarizes in this beautiful review here, is when you look at the science on B vitamins for mood, all of the work is done on high, what we might call high dose. I call it a good dose, perhaps, or a more optimal dose of well beyond the RDA. And there are reasons for that. One of them is that sometimes we need these higher doses to activate sort of lazy enzymes and genes in some people. They have a sort of genetic predetermined higher requirement for nutrients sometimes. So I will mention a few products very briefly. One of them that is just a B complex that Pure provide is called B complex plus, which you can review there, but I don't really need to go into that. Moving into the next nutrient, it's magnesium. Now, for me, magnesium, again, is just one of these fundamental nutrients you want to consider, arguably, with most patients. By statistics, every patient you'll see will have a magnesium deficiency. That's what we see in the general population when you look at epidemiological and observational studies, is that basically everyone is deficient. It's just one of those nutrients that sits at the very top. And the reason for this is there's a multitude of reasons, but it's largely because of a combination of poor diet and increased physiological demand. And paradoxically, you have a higher demand for magnesium under stress, and you also excrete a bit more as well because you're utilizing it more frequently. So this is something to take into account. And we know that it helps people. When you prescribe magnesium, it works. This is just one clinical trial. There are several now. Since this was done in 2017, there's been several more published, and there were a few more before it. But it's just one good example where they gave only 248 milligrams of magnesium for 6 weeks. This was in patients with clinical depression, and they found significant improvements with anxiety within 2 weeks, and then, continued to be significant at 6. So it definitely works. We have the evidence there, and it's certainly something to consider. We know the reasons it's working. It's a cofactor and key nutrient that really catalyzes and involves in hundreds of processes throughout the body. But in the central nervous system, it's involved in more inhibitory neurotransmitter function, meaning it calms down the brain a bit through neurotransmitters like GABA. And it also dampens the cortisol response, as we can see in this study of patients with insomnia here. They received magnesium, and there was a significant decrease in serum cortisol as a part of their physiological response. So there's lots of different magnesium you can use. I'm a fan of magnesium glycinate as a form for stress. And the reason I choose different types of magnesium or discriminate amongst different types is got nothing to do with bioavailability. I think most of the arguments around bioavailability are rubbish when it comes to magnesium. But what for me really matters is the cation, the anion, or the compound, the ligand that the magnesium is bound to. In this case, it's glycine. Now, this is cool because you actually get a lot of glycine. So there's a few grams of glycine when you start prescribing a few capsules a day. And that's interesting because glycine has a physiological effect, and it also has a neuroinhibitory type effect, and also has been shown to help patients with insomnia in independent clinical studies on just pure glycine. So I really like it for nervous system type disorders because I think you're getting potentially an added benefit of the glycine there. I've just dropped a really quick reference to why I would choose different forms, just glycinate versus citrate. They're my two preferred forms, and I would tend to use citrate more for low energy and fatigue because of the citric acid. It's a Krebs cycle intermediate. And again, like glycine, there have been independent studies on pure citric acid without the magnesium, and it relieves fatigue. So it's certainly has some clinical value. So moving from magnesium into vitamin C, again, it's really simple foundational nutrients, but vitamin C concentrates in the brain. The highest preponderance of vitamin C in our body is in our brain and in our adrenals. And it's not by chance that it's sitting there. It's involved in the physiological function of these organs. Vitamin C deficiency or severe deficiency as scurvy is very rare in the modern world. But what isn't rare is a suboptimal level of vitamin C in the general population. It can range from about 10% in the general population, so that's 1 in 10 people, to about 30% in high-risk groups like the elderly, inpatients, people with depression, and people with chronic disease, so on. So there's a 1 in 3 chance, if you've got a very sick patient in front of you, is that they have a suboptimal level of ascorbic acid in their blood. And that is really important for many different reasons, but very important for their mood. And it has been shown, vitamin C, to improve mood. And I'm sorry I don't have a better reference. This is an old editorial I wrote in an obscure magazine in 2018. But what I did is I reviewed a lot of the clinical studies of vitamin C and anxiety and HPA Axis dysfunction. And basically what you can see from the medical literature is that there are several human clinical studies in which it's been shown to reduce stress, reduce anxiety, reduce work-related fatigue, and even reduce symptoms of depression. Typical doses in these clinical trials are 1,000 milligrams in divided doses. So any good vitamin C capsule will have above 500 milligrams in a cap anyway, and you just give 1 morning and night. It's important to divide the dose because at that sort of dose range, you get a better sustained blood level when you split the dose to morning and night. And it seems to work. Like, it reduces oxidative stress, it improves neurotransmitter activity, experimentally, and it has been shown in humans to reduce cortisol as well, which is really neat. So again, very simple, very low cost, but worthwhile considering some of the basics again. Of course, Pure have a vitamin C, buffered, pure ascorbic acid, liposomal, whatever you want, it's there. And of course, many other brands do too. There's no patent on vitamin C. Everyone's got a good one. So moving on from vitamin C, I want to speak briefly to omega-3 fatty acids. Now, you can't really think about nervous system function without thinking about your patient's omega-3 fatty acid status. And I can't underemphasize this relationship. So you really need to check it, would be my advice. And I mean, do a blood test. And a very basic place to start, and for me, the best validated, is what we call the omega-3 index. So the omega-3 index is just a red blood cell ratio or percent of EPA and DHA, that's eicosapentaenoic acid and docosahexaenoic acid. They're the sort of downstream forms of the omega-3 fatty acids that are important for the brain. And they need to be provided as as those forms in diet. So they're exclusively from fish and animal foods, although there are some algae sources available supplementally. So anyway, what we're looking at here, and the reason I really am a big fan of the omega-3 index is because it has lots of wonderful science behind it. There have been huge studies all over the world in different populations, predominantly for cardiovascular health, but a lot for other conditions as well, like depression. And what we're looking at here is the omega-3 index level. In the context of cardiovascular disease, these three arms on the right-hand side here in Japan, UK, and US, we have the average omega-3 index. So it's usually above 8 in Japan, very high consumers of seafood. In the UK, I'm surprised it's high. I've never seen it this high in patients or anyone really, but the average is reportedly been quite high. This comes from published research, so I don't want to knock it too much. And the US average is a bit lower. What has been proposed is that you want to be up in this low risk level of above 8 with the omega-3 index. When you start testing patients, they often won't be there. And you'll often be surprised at how much omega-3 they need to start consuming to get up there. It can be upwards of around 2 grams a day. Anyway, so what we know about things like major depression and bipolar depression is that people are generally, with psychiatric disorders, well below an optimum. In fact, they're sitting at a very low level on the omega-3 index here. Now, if you have a patient with a low omega-3 index, it tells you things about their biology. And one of them is it tells you that they need omega-3, of course. And we know that some people respond very well to omega-3 fatty acids. I would argue that it needs to be personalized, the omega-3 index, and we'd see much better results in studies if we did that. But in general, even without personalization, none of these studies in this meta-analysis use the omega-3 index to personalize care. Even without that, you see a good, robust response in terms of mood after omega-3 intervention. We also see improved reactivity to stress. So if people are low on the omega-3 index, in a sense, that's telling you that they have poor stress reactivity. And they'll have a high secretion of cortisol if they're low on omega-3. And if you correct that by supplementing omega-3, as they did in this trial, their stress adaptation gets better. But the coolest thing for me is that for those of you who have been diligently taking fish oils for years, you can give yourself a pat on the back because your brain's bigger as a result of it, or eating fish, obviously, or omega-3 rich foods. So what we're looking at here is a cross-sectional study in looking at the omega-3 index in comparison or relationship to hippocampal volume. And what this study was able to show, and this has been replicated several times since in different populations, but this was the first, is that as your omega-3 index goes up, your brain volume improves, and it's the hippocampus. So this really important area that we want bigger because it helps regulate the stress response. So we think that this is one of the reasons omega-3 fatty acids are improving adaptation to stress, is that they're impacting the brain's structure and function. So how much omega-3 fatty acids do we give? And the general consensus in nutritional psychiatry research is that, one, you should personalize it based on the omega-3 index, but generally speaking, 1 to 2 grams a day will be sufficient based on what we know about clinical and biological response to supplementation, which has been really well documented now. So I think test the omega-3 index and then prescribe 1 to 2 grams, obviously in conjunction with food sources, but taking that into account. So Pure, of course, have omega-3 fatty acid products. EPA and DHA Essentials is a 500 milligram per cap dose. And there is a 1 omega, which is 1,000 milligrams per cap. So to summarize some of the things we've spoken about, I'll put a quick reference table here. So we have, B complex at the top here, some indications why to use it, typical dosage considerations, and then the same for magnesium, vitamin C, and EPA, DHA. But quickly, as we wrap up now, I'd like to move into just 3 more things that I think are useful tools to consider when you're managing people with chronic stress. And the first is ashwagandha. So ashwagandha, or Withania somnifera, has a long history of traditional use for stress resilience and adaptation and mood. But what's really striking about it is the science has caught up. So it arguably is the best studied natural product for anxiety. There are at least 5 or 7 randomized controlled trials now at minimum. So it definitely has a preponderance of evidence, and it works really well. So this is an old meta-analysis looking at 5 human clinical trials, but there have been quite a number published since then. Basically, we know it works very well for symptoms of anxiety. It also works for things related to hyperactivity of the HPA axis, like stress-related eating, as you can see here. It's also been shown to help manage insomnia. And here we're looking at an effect of ashwagandha on some of the metrics used in a clinical study. The first 3 bars there being rating scales for stress and anxiety, and the last metric there being serum cortisol. So as you can see there, it has quite a profound effect on symptom scores. Basically, these people were symptom-free in this particular study at the end of 2 months. And there's quite a robust effect on lowering elevated cortisol. So obviously, Pure have ashwagandha. This is a 500 milligram cap. So just 1 a day is all that's required. I like to prescribe it in the morning. I just think logically it's a good time to administer it, preferably with a nice coffee. Joking. So the second thing to consider is rhodiola. Now, rhodiola is another herb, different place of origin. It really comes from the Nordics and northern Russia and northern China. It's a beautiful plant, and it grows in harsh, arid environments on rocky outcrops. And I think this speaks to its resilience as a plant. But interestingly, maybe the biological compounds it makes to improve its resilience in its own environment benefit humans, because it has been shown to improve adaptation to stress. Has quite a different effect, in a sense, to ashwagandha, although it reduces anxiety as well. It's not a stimulant. It does tend to have a more pronounced effect on fatigue. So there are several studies in which rhodiola has been examined for stress-related fatigue specifically, and it improves the cortisol awakening response and also improves mood and lifts symptoms of fatigue. Now, clinically, I can tell you it can be quite pronounced sometimes. Actually, when I first started using rhodiola, I had a patient come back to me and say, is this stuff legal? Because they had such a good clinical response. And you do see that occasionally. Sometimes within a few days, people really notice it. But typically, it's gonna take about a month to start to see a good clinical response. This is a clinical trial of rhodiola rosea in anxiety disordered patients. As you can see here, a good robust effect within 10 weeks, and here in depression and so on. Very simple formulation. We've got a 100 milligram cap in the pure encapsulations range. Personally, I think minimum 2 capsules in the morning, and I would go up to maybe 3 capsules once daily if you think someone needs it, which is a little bit off-label, but will give you a good dose. Rhodiola is something where you need to really administer it before, not after lunchtime. And it's not that it's stimulating per se, but it does acutely elevate the activity of the central nervous system. This has been documented. So, you know, if you do have someone who's really prone to hyperarousal, it's better not to give it in the evening, but don't tell them it's going to cause anxiety, because it will. That's a potent nocebo effect. It won't, it'll reduce anxiety, but it can, you know, have a slightly stimulating effect in some people. So good to be aware of. And then the third and final thing I want to touch on is L-theanine. Now, L-theanine is an amino acid that was isolated from green tea in Japan in the 70s and has been identified as a key factor within green tea that is responsible for its relaxing and cognitive enhancing type effects. So there have been quite a few trials of green tea, L-theanine, and essentially what we know is it has a mild relaxing effect, useful for down-regulating the stress response, and particularly pronounced for people who have difficulty sleeping. So there have been clinical trials of L-theanine in patients with stress, including, you know, subjects like students, but also psychiatric patients with, you know, different affective disorders. This study's in students. Typical dose is 200 milligrams twice daily. And if you're using it as a sleep aid, the typical dose is 200 milligrams about an hour before bed is a good way to use it. So I won't go into things around purity, but just know that pure encapsulations, L-theanine is the pure stuff, basically. There's no, it's a high quality extract using sun theanine, which is what all the research is on. And it's a 200 milligram capsule. So 1 capsule twice daily if you're using it to manage chronic stress and anxiety, but 1 capsule before bed is enough if you're just using it as a sleep aid. So there's, again, a quick summary chart there of everything we've discussed: ashwagandha, rhodiola, L-theanine. Here looking at clinical indications predominantly, and then just suggested use for your reference. So we've covered a lot of ground. We've gone into a bit of the stress biology, and then we've looked at how nutrition intersects with that, looking at some of the fundamental non-negotiable sort of nutrients that are involved in the stress response, and then touched on some of the things that we can then start personalizing to different clinical presentations, whether someone's hyperactive, burnt out, or you know, maybe has comorbid insomnia. And I think where all of this comes back from, and hopefully what I've grounded this in, is the old idea that really when we think about mental health, we really should be thinking about nutrition, because the biology of the central nervous system is dependent for optimal function on nutrients. And as the late, great David Horrobin put it, is that without really understanding this, we're completely missing the picture. And mental health professionals would be well advised, using his words, to learn some nutritional biochemistry and keep abreast of this area of scientific development. And thankfully, you know, when he wrote this in 2002, this definitely was not happening. But, you know, in the last few years, people have really taken notice, and we're starting to see a real phase shift in the awareness of the interconnection between nutrition, stress biology, and mental health. Thank you.
Excellent presentation. It's good to be reminded of the foundations and in what we are working with as nutritionists, for sure. So there's of course some questions that have come up. I just want to let you all know that at Nordic we have been looking into the omega-3 index. We already offer it, but it's quite expensive. So we are offering we're going to offer an omega-3 index that should be a little cheaper than the one that we have right now. And that should hopefully show up in about 1 month's time. And that would allow, to have that consideration and do that test, including when you have stressed out patients. So a question could be doing cortisol tests, because now a lot of what the publications you looked at was like cortisol in blood, etc. But is that something you still recommend? We do a lot of like Dutch tests and
yeah, 100%. Yeah, absolutely. It's sorry I didn't go into testing, but I should have, really, knowing the group. But absolutely, salivary cortisol is essential. Like, it's such a useful tool for measuring the biology of the stress response. It can really help you understand the patient and also help personalize interventions based on what we've just seen. If someone's hyperactive or hyporeactive or somewhere in between, you can start combining things. It's really insightful. And I'm old school, so for me, I'm a fan of 24-hour, the multiple samples across the day. But I really like the awakening response as well. I think that's really valuable. So, using Dutch and other, salivary assays is a really good idea in practice, to my mind.
So we could have a very good test pair here. That could be the omega-3 index combined with a cortisol measurement, maybe even into a DNA resilience test. I might want to share you that presentation we did last month with you, Ben, just for your information. But then, of course, questions comes up from our practitioners who are bright people out there. So they of course question what you're saying, and then in regards to the theanine and what about if you have COMT gene and you shouldn't be taking green tea, and is it okay to take theanine? What's your comment?
Yeah, absolutely fine. The interaction between COMT and green tea is to do with the catechins, which is not the theanine, and pure theanine is catechin free. So definitely the pure encapsulations product is fine. There are some brands that extract from theanine from green tea, so you'd want to watch those, but pure's theanine is absolutely fine.
Some theanine is not.
Yeah.
Mm-hmm. And then yes, recordings will be available. There was one who asked a little bit into more details. That was a question of 1636. Let me just scroll down and see what came. It was more questions in regards to the study with high dose secretors, and in regards to variability within the same person, and had they slept well, had they not slept well. So a lot more like detailed, and I guess the references in the slides. So I think the best one is for Atul Kamour-Berg to get the research out. But you might want to just quickly comment on this.
Yeah, definitely they wouldn't have controlled for a lot of those like nuances and variables. It was just like taking people as they are and seeing how they respond to stress. But it's a good point. A lot of environmental things will influence our sort of adaptation and stress response. But I think generally speaking, the way your HPA axis is sort of chronically functioning in this way is probably quite reproducible in a sense, and not as, intimately affected by those things. But it is a very good question, and I'd say the answer is no, they weren't controlled for.
Super. So then, if we were to, you have that slides with the rhodiola and the ashwagandha and the vitamin C and the omega-3, etc. There's a much more specific question, as in how do we dosage it throughout the day? Maybe you want to put up the slide again and give us.
Yeah. Well, firstly, it needs to be personalized, so you don't necessarily need to give everyone everything. And I think just on a very practical level, there's not a lot there. Like, personally, I take a lot of these things just every day as a maintenance, like multivitamins, some fish oils, and magnesium, some vitamin C is like, there's like 4 capsules, or, maybe 6 if you're upping the magnesium. So that should be pretty easy to take with breakfast. And then, if you want to add in one of the other things, you just add it in on top. It's, for some people, if they're not taking pills, 6 to 7 pills might sound like a lot, but it's not. And it's good to communicate to the patient too, that it's not necessarily a long-term strategy, and the prescription will be reviewed, and the ultimate goal is to have them on as little as possible over time. So I hope that helps a little bit with dosing. I will add also, I think giving things with food is always a good idea, and I can't think of many exceptions to that. I think it really just helps people remember, and it also minimizes any gastric discomfort that can sometimes happen with taking vitamins on an empty stomach.
Yeah, we're dealing with people who are stressed, depressed, and then looking after themselves and getting all the good vegetables and cooking all the good food and taking all the supplements can be a bit of a
challenge. Yeah.
But I think from your presentation today and taking some of the highlights out of this, maybe this knowledge, and that's where I always use knowledge to empower and inspire patients and explain from research or clinical experience what happens, and then hopefully through this knowledge we can inspire them to make a pack of 3 or something with their supplements 3 times a day, so they can take that and try and encourage them to do easy cooking and get the fish on the plate as well. But knowledge is empowering for sure.
Yeah, it's beautifully put. I think you're absolutely right. If you're a good teacher, the compliance will improve. Yeah.
Exactly. So well, thank you very much for your presentation, for sure. It's been very enjoyable for me to listen to you, and I hope a lot of you out there both learned and found some inspiration. And then I'm just gonna shout out about the conference in Stockholm that we have as well. And of course, look out for emails, because we do send out emails, and we will send out emails with the recording from now, and also the slides to you all, so you can use that as inspiration. But reach out anyway if you have questions, or if you just want to chat with us or get some more information about any of the things that we're doing. So, but Ben, thank you very much for today, and make sure you take fish oil and ashwagandha, etc. the next few days, because you will be needing it. I know I have my stash with me here because I'm at a conference as well. So, and thank you all out there for your time. Thank you.
Yeah, thanks for having me. It was a pleasure.
It was my pleasure. Bye.
If you do not already have an account with us, please contact our team and we will assist you. If you found this webinar helpful, please like and subscribe to our channel.